Assalamualaikum Dr. Trainees. I am Dr. Untara Shaikh. I am the Academic Program Director at Mass-Smarter USMLE Test Prep based in Atlanta, Georgia. I'm so excited to be part of this great project, and today we will be going over the questions that you guys have submitted based on your rheumatology lecture. I hope you will benefit from it, and I tried to make it as interactive as I could. So let's start with your first question. So the first question that you guys are asking us, tell us how on clinical examination we differentiate inflammatory and non-inflammatory arthritis. So what is the difference between inflammatory and non-inflammatory arthritis when the patient comes to your clinic and you haven't done any lab work, okay? You haven't ordered any blood work. So how you will differentiate it? So what you will going to ask the patient, number one thing, that you have pain early in the morning more or in the evening. So if the patient says, in the morning, I have more pain, okay, it takes me about more than 40 minutes to just get out of my bed, and it's very hard for me. So that's going to be your inflammatory. For example, we have rheumatoid arthritis and SLE. They both have that kind of but rheumatoid arthritis has more pain in the morning than any other. So, and then other thing is these inflammatory arthritis, they affect the same joints on both sides. Okay, that will be the other on the question that you will be asking. The other question that you will be asking, okay, if what is happening, if it get worse with the movement or with it relieves with rest. So what happens with non-inflammatory arthritis, patient will tell you that, yeah, whenever I'm working, it's movement, it hurts. When I sit down and I'm resting, then it's better. And then your non-inflammatory can affect one joint or both sides, symmetrical also. So I have prepared over here the difference between these two also. You know that inflammatory means inflammation is happening. And inflammation has some signs, okay? When inflammation is in the body is happening, we see that patient will complain of erythema, swelling, warmth, and pain, and loss of function, okay? So in this case, loss of function will be, doctor, it's very hard for us to get up early in the morning and start my day. Okay, that's going to be inflammatory. Do you have any swelling there? You will see soft tissue swelling. Okay, erythema, is it red? Yes, sometimes it's going to be red. Is it warm? Sometimes it's going to be warm. Okay, then they might have some systemic features associated with it. So an inflammatory arthritis patient comes to you and they said that, yes, I have some mouth ulcers. Yes, I have some rash with it. So SLE patients have those symptoms also. But your non-inflammatory, they don't have any systemic features. So that's also on clinical basis that you can differentiate. The other thing that, okay, I know that you just asked about on the basis of clinical, how you're going to explain, but when you order the labs, your ESR and CRP proteins will be high in inflammatory. Because what is happening, why they are high in inflammatory and non-inflammatory doesn't have any lab values like that? Because what is happening when your body is under stress, okay? We have, for example, inflammation is going on, like rheumatoid arthritis. So these are called acute phase reactant proteins. So these reactant proteins, they increase when the body is under stress. That's why on the lab values, you will see increased ESR and CRP in inflammatory arthritis. Then you will say that, okay, let's tap the synovial fluid out. So on the synovial fluid, you will tell them to count their WBCs. If the WBC is more than 2000, that's your inflammatory. If it's less than 2000, that's your non-inflammatory. Okay, so on a clinical basis, when the patient comes to you, the number one question you're going to ask is, where is the pain? Is it affecting your both hands or both joints, like legs, knee, whatever they have the pain? And what pain level is in the morning or in the evening. If the patient says, I have more in the morning, that's going to be your inflammatory. If it says, okay, when I rest, then it's relieved, that's your non-inflammatory. And that will, towards the end, when they will be done with their work and towards the end, that will have this pain. So the second question that I have over here is, should every patient with joint pain be thoroughly evaluated? So the evaluation should determine whether the joints, periarticular structures, or both are the cause of symptoms and whether there is inflammation. Okay, so its evaluation determines that, it's based on that. If they have extra articular symptoms and findings, which may suggest that they have some systemic symptom going on, systemic diseases going on, and that's why. But there are some red flags. The red flags are the one that you really need to pay attention and tell the patient that I really need to evaluate you thoroughly. Like I need to take your blood samples and do x-rays, things like that. So red flags are going to be that joint warmth, swelling, and erythema. If you see the patient's joint is warm, swelling is there, and it's redness, okay, that's going to be the one. And then any extra articular symptoms are there, like the patient complains to you that, doctor, I have fever, I got rigors, I got rash, I got chills, I have plaques. You can see that I have mouth ulcers. Look at that, my eyes are red, conjunctivitis. I cannot see properly. It's hurting my eyes, uveitis. I think my heart is racing too badly. So that's murmur is going on. Look at that, my skin has some kind of purple things coming out. So those will be purpura. Oh, I don't know why I'm losing weight. So these are all some extra articular symptoms the patient will complain to you. And each of it is associated with joint pain, okay? Like I had given you example before, systemic lupus erythematosus, patient can complain with, I have rash, butterfly rash, around that, malar rash it called it, and then they can say we have mucosal ulcers also. And also eyes are affected, uveitis. When you see those extra articular symptoms, and joint warmth, swelling, and erythema, so you are going to evaluate the joint pain thoroughly. The next question that I have is, how is osteoporosis related to osteoarthritis? So osteoporosis is often confused with osteoarthritis, since often patients can have both diseases, okay? While they have different, the name is confusing, osteo, but they are totally different conditions, diseases. And what is osteoarthritis? Osteoarthritis is degeneration of the joint cartilage, okay? And it can cause pain, swelling, and stiffness in the morning. Whereas your osteoporosis, they have bone loss, bone mass losses there, and it's associated with that. So they have these two differences also. They are entirely different diseases, and they have similarity in their names, but they develop differently. They have different symptoms, and they are diagnosed differently, and they are treated differently. So this is, but they do have some of the risk factors. They are common for both of them. Like we got over here, age is there, gender is there, genetics, inflammation or chronic inflammatory diseases, some medications, and then unfavorable body composition. So, but osteoarthritis patient will be obese, whereas your osteoporosis patient will have low body mass. Osteoporosis patient will be immobile, and then your osteoarthritis patient will have more use of veggies. So when they are overusing it, so then they will have more pain. So smoking, alcohol, low body mass, and immobility, these are the risk factors for your osteoporosis. And osteoarthritis, occupation, trauma, intense sports activity, or obesity, mechanical overloading. So these are different. Look at the risk factors are different. So they are entirely different diseases. They are diagnosed entirely different, and they are treated entirely different. But one thing is common between both of those: pain strategies, coping strategies, because they both have pain, right? So the coping, the treatment, the management is giving for them is same: exercise, rehabilitation, right? Stretching, you do it. So both of the diseases, you are going to tell the patient, hey, you need to do these exercises. So what is happening? Most patients with arthritis will use pain management strategies at some point, but this is not always true for the patient with osteoporosis, okay? So usually the patient of osteoporosis will need pain relief when they are recovering from a fracture, because they are prone to fractures, like older people are having it. Senile osteoporosis, when people are old, when this is happening, so they are more prone to fractures, and when they got some fracture, then they will be like, okay, I need pain management for that. But whereas your osteoarthritis patient, since day one, they will be like, okay, I need pain medicine. So when osteoporosis have fracture, then they will be asking you that. So So what is they are saying that in cases of severe osteoporosis, when multiple spine fractures, pain control may also become as a part of their daily life, right? So because there's multiple fractures are there, so they need to take some medications, and that will become their part of their daily activities, daily life. Regardless of the cause, pain management strategies are similar for patients with osteoporosis, osteoarthritis, and rheumatoid arthritis also. So the next question we have, can you please show us X-ray with signs of osteoarthritis? As most patients bring X-rays along, so how to look for subchondral sclerosis, bone cyst, how they look like. Okay, so here is the thing. I'm going to show you the X-ray findings, but before that, I would like you to take you back a little bit that how these findings are being produced. Okay, what's the pathophysiology behind it? So that's why you can better understand. So number one thing, what is osteoarthritis? It's the wear and tear over time erodes the hyaline cartilage, right? So your hyaline cartilage is being damaging. So what happens then, we have decreased cartilage between two bones. So this is over here, we got two bones, right? So two bones, the cartilage between that will be eroding. So what we got then? Narrow joint spacing. So, but that's not specific for osteoarthritis, because rheumatoid arthritis X-ray will also show you narrow joint spaces. Okay, that's fine. Then we got our increased bone-on-bone contact. Bone-on-bone contact, like they are kind of contacting each other like that. So what is happening? Synovial fluid is under pressure, is forced into the defects in the articular bone. So what we see over there then, they have pockets of fluid, pockets of liquid under the remains of the hyaline cartilage. So whatever the hyaline cartilage remains are there, we see that over here they made a pocket, and that has liquid in it, fluid in it, and that's your subchondral cyst. That's going to be subchondral cyst. If you look pretty closely down there, you will see a dense black color shadow, kind of ball-like thing. That's your subchondral cyst. Subchondral cyst has the other mechanism also. They can be formed because of bone resorption at some subchondral areas. So bone resorption, who does it? Osteoclast. Okay. So when we have imbalance between osteoclast and osteoblast, so osteoclast is working and they're going to cause bone resorption. So what happens? We have some kind of bone resorption at some areas of the subchondral. So over there again, the fluid is undergoing and they are making a pocket. So that's your subchondral cyst. On the other hand, what we got over here? We got over here now osteophytes. Okay, so what is osteophytes? This is our abnormal bone. This is our abnormal bone deposit, spurs surrounding the joint space. So abnormal bone spurs surrounding the joints. Subchondral sclerosis, what is that thing? Thickening of bone directly under the areas of bone to bone contact. So you see that the white shadow over here is a thickening of the bone is there. Okay, what is happening? Thickening of the bone directly under areas of bone or bone contact. So this is like we have under bone to bone contacts is happening too much. So you will see a white shadow. That's going to be your subchondral sclerosis. If you see right here, a black dot is there and they got fluid. That is going to be your subchondral cyst. Okay, look at this picture also. I got over here osteophyte. What was osteophyte? A spur, bony spur. Sclerosis was your thickening, extra thickening, right? Because of bone or bone contact. Look at this one over here. Sclerosis again. Displacement is happening. Question number 5. Are vitamin D and calcium level checked routinely in patients with osteoarthritis? So measurement of vitamin D and calcium levels and supplementation with oral vitamin D and calcium has become commonplace in your clinical practice. So yes, we are routinely checking these two levels in patients with osteoarthritis, rheumatoid arthritis, and like yearly checkup is there. So patients have been checking for that. It's a routine schedule thing is now. So the next question I have is stem cell implant is new launch treatment. Is it beneficial to treat osteoarthritis completely? Yes, so what is happening, our stem cell therapy has been demonstrated to induce profound healing. Because what is happening, our stem cells are unique, okay, because they have the ability to renew and regenerate. Throughout our life, these stem cells continue to renew and repair organs and tissues. So this is what I will show you over here. Reduce the inflammation, fight apoptosis, muscles, they are regenerating, bone is being made, fat and cartilage, and self-replicate. So this is why what happens, throughout our life, the stem cells continue to renew and repair organs and tissues. So using your own body, adult stem cells can help rebuild and regenerate joint damage in the body. Okay, so adult stem cells can help you rebuild and regenerate joint damage in the body. But what they have seen, what they are talking about it, if you want the perfect thing, so they said that through administration of umbilical cord tissue derived mesenchymal stem cell, we have seen improvement in our osteoarthritis patient with that. So now what is I'm saying? In umbilical cord tissue derived mesenchymal stem cell. How are you going to get umbilical cord things? This is how you're going to get it. We will get the consent from the parent, because umbilical cord, who got it? New baby, right? Newborn. So neonate got it. We will tell them, the parent, we need that. When they clamp the cord, and from after that, they are going to draw the blood, okay? Then they will run it, take out something that's bad, is gone. They freeze it to about minus 190 centigrade. And when whoever the patient is there that's eligible for this stem cell therapy, they inject that. So this one, umbilical cord stem cell therapy, have shown improvement in adult osteoarthritis. Okay, this is what they are doing. So it's kind of pretty risky and hectic to find a parent and ask their consent and go through that, but it does help. I have another picture over here for you guys. 6 stages of stem cell therapy. What are those? So stem cells move from bone marrow to blood stream using chemotherapy and synthetic growth factors. Okay, synthetic growth factors are there. So then what are we going to? Machine collects the blood and separates out the stem cells. So from blood, you are taking out the stem cells. Then stem cells are being frozen. Okay, so then again, more chemotherapy is usefully or partially to wipe out bone marrow and immune system, because the immune system is the one that's not working properly, right? We need to repair that. So this is what I'm saying, that your stem cells are not just helping to regenerate or repair, right? So they are going to help you develop your immune system also. From bone marrow, we are going to make our immune system basically. They are making RBCs, they are making WBCs, they are making our lymphocytes, right? T cells, B cells are coming from there. So patients who need to rebuild their immune system, we can use stem cells. So they said that then we will inject the patient with stem cells, okay? And then body recovers over a period of 3 to 6 months, sometimes longer. So if you are talking about just the osteoarthritis, then you need to say that we need to use umbilical cord mesenchymal stem cells, okay? And that being very effective. The next question I have is, please explain the role of PRP treatment in osteoarthritis and joint pain. So number one thing, what is PRP? PRP is your platelet-rich plasma. So platelets are type of the cells within our blood. They contain growth and healing factors. So growth and healing factors. So when we concentrate it and inject into the damaged area, so these platelets are the one, they release the growth factors and stimulate the body to heal itself. So how we are going to do, we are taking the blood, we are collecting the blood from the patient arm. Then we are going to separate the platelets and then extract the platelet-rich plasma and inject into the area with PRP. And then you just inject into the patient. So PRP injections are non-surgical treatments. So we can use for tendinitis also, like tennis elbow, rotator cuff tear. We are also using for muscle strain, okay? We are also using for osteoarthritis. So these are the ones that we can use. So, but mostly basic concept is that your platelet is carrying the healing and growth factors. So when you inject that into the patient, that's how they will cause the healing. I hope it helps. Next question. Any new modalities for treatment of osteoarthritis be developed which show promising results? We just talked about stem cell therapy, okay, that's giving you promising results. And there are some drugs been in process, or there is one drug that's been in the market in US also, and then they are about to launch in Pakistan also. It's going to take some time though, but they are showing the promising results, because these are the drugs that what they are doing, they are preventing the further destruction. Okay, you need to stop the progression of the disease, because the current treatment, what are they going to do? Dr. Saab, I have a pain, you're going to give them NSAIDs, right? Acetaminophen, topical capsicums are given. But what is happening then? They are just targeted towards the pain relief. They are not stopping, they are not preventing from the disease to progress further. So the new modalities are the one, they have been promising and they are working on it, and they have shown good results. Next question I have is, there have been some studies indicating that supplements like glucosamine and chondroitin sulfate provide benefit in osteoarthritis against cartilage degeneration. Is it useful in practice and being prescribed in Pakistan? If so, any improvement observed? So yes, look, this is the thing what is happening. Glucosamine and your chondroitin sulfate alone or in combination may not work for everyone with osteoarthritis. Okay, so your chondroitin sulfate is providing pain relief, additional pain relief in a patient of osteoarthritis with knee and hand. So they give you about improvement. They have seen about 8 to 10% improvement in pain, because they work very slowly. It takes them up to 3 months to start working. So by the time the patient has to take other medications also, right? And then glucosamine on the other hand, they said that they have shown the pain relief also for some patients with osteoarthritis of the knee, hip and spine. So because your glucosamine is very safe, okay, so the patients who cannot tolerate NSAIDs, we can give glucosamines to those patients. They need long-term treatment. So this is, but the patients, however, the patients who have been taking it and who have seen the improvement, they should not stop it. They need to keep taking it, because both of them are safe to take it. So yes, in Pakistan, we do ask patients to take these supplements because they are helping them additionally to improve the pain. The next question. Mostly levels of uric acid in blood are checked to diagnose gout. Is there any blood test for gout, pseudo-gout? No, there is not any blood test to test for pseudo-gout, as most patients reluctant for joint aspiration and most physicians are not also skilled to do it. So what are you going to do? You are going to do x-ray for them. Okay, so what are you going to see on the joint thing? We are going to see calcium pyrophosphate crystals. Like in this x-ray, you are going to see these depositions over here, the line I'm showing. These are the crystals that are being deposits. So there is no such thing that you can diagnose pseudo-gout on the basis of blood level, and there is no any blood test. You can offer the patient to do the x-rays. Based on x-ray, you are going to see the crystals, calcium pyrophosphate crystals deposition will be there, and that will be your diagnosis for pseudo-gout. Next questions. What medicines are prescribed for rheumatoid arthritis? So I'm going to give you a list of certain medications that we prescribe for rheumatoid arthritis, and after that I would like to go over how you will do that management completely. Okay, what is the order that you will be giving it to them? So we have few medications. The patient comes to you initially, you give them acetaminophen, you can give them NSAIDs. There are different types of NSAIDs, ibuprofen, naproxen is there, and then topical agents are there. COX-2 inflammatory inhibitors are there, DMARDs are there like methotrexate, sulfasalazine is there. Then we have biological agents like tumor necrosis factor alpha inhibitors, and then glucocorticoids. So these are the bunch of drugs that we can prescribe in the patient with osteoarthritis or rheumatoid arthritis. Sorry, not osteoarthritis, rheumatoid arthritis. So your NSAIDs and COX-2 inhibitors, what are they going to do? They are for symptomatic relief. Okay, they are not going to reduce the destruction. They're not. Whatever is the disease progression that happened is going to keep happening. So, and then your glucocorticoids on the other hand, when the patient has a flare, it has severe pain, and that comes to emergency department, we give them glucocorticoids. Because what are they going to do? Relieve the symptoms, and short-term relief is there, okay? But again, not effective in preventing the eventual joint destruction. So what are you going to do? You are going to start DMARDs, okay? You are going to start DMARDs as soon as possible. Because what is happening, why DMARDs you need to start? Because again, as soon as possible, because early in the course of a disease, joint destruction starts. The preferred we have is methotrexate. So methotrexate is our preferred DMARD, but before we start it, we have some conditions that we need to be very careful, and we are not going to give it to the patient. So the following are contraindicated for methotrexate. So pregnant lady who is planning to get pregnant, patient with liver diseases, patient with renal insufficiency, or patient who has excessive amount of alcohol intake. So these are the contraindicated. Okay, these are some contraindications for methotrexate. Also, you will check their hepatitis B and C panel. So when you are done, you see that, okay, nothing is wrong. We need to give them methotrexate now because it's a preferred one, because it has good efficacy. Okay, so you start with them. So what happens, you see that patient still complains of the symptoms, and it's been more than 6 months. So what are you going to do now? You are going to have two things. You have a step-up therapy or parallel therapy. For step-up therapy, number one thing, we will add the biological agent. So biological agent, we have tumor necrosis factor alpha inhibitor. So what are those? Like infliximab, and we have our epinephrine, we got etanercept, infliximab. So these are our tumor necrosis factor inhibitors. But before we do this, give this drug, we have some condition that we need to look for. We will do PPD testing. We will test for TB. Why? Because this tumor necrosis factor alpha inhibitor is the one that will go and inhibit your tumor necrosis factor alpha that is maintaining the granuloma in TB patients. So when you give an inhibitor, tumor necrosis factor alpha is not going to work and granuloma will be destroyed. Okay, so what will happen? Reactivation of a latent TB. Okay, so if a patient has PPD positive, you're not going to give them tumor necrosis factor alpha inhibitors because they have granuloma formation over there. We don't want granuloma to be destroyed because our tumor necrosis factor alpha inhibitor is keeping that intact. So be careful. Before you start that, you need to do PPD testing. You add up with that, but now what happened? Still no response. Patient still complains to you that I don't think anything is happening to me, I'm not feeling better. Then you will switch to alternate tumor necrosis factor alpha inhibitor, and then you will continue methotrexate. Okay, the other choice was what we have, parallel therapy. So add non-biological agent, that you will add sulfasalazine, hydroxychloroquine. So these are being added to your methotrexate. Then you can go and have a step-up therapy also, same thing. Add the biological agent. If inadequate response, switch the tumor necrosis factor alpha inhibitor to the other drug and continue methotrexate. So I hope you guys are understanding that how the management works. So we have this list of medication. You can tell the patient to take these medications, but what is most important? You need to stop. You need to prevent the disease progression. And who will do it? Methotrexate. DMARDs are going to do it, right? So you're going to start methotrexate as soon as possible when you see the disease is growing, okay? The disease is progressing. Patient's symptoms are getting worse. Then you start methotrexate. Next question. If a patient having RA factor positive along with minor joint pain, morning stiffness, but ESR is normal and NAA and anti-CCP is negative, which medication should be prescribed? So let me tell you one thing, that RA factor is positive in a normal healthy individuals also. A lot of population, they have this positive too. So if a patient comes with RA positive and you're thinking that it is rheumatoid arthritis, so that's not diagnostic at all, because you will find RA factor in other healthy individuals also. If you see that ANA is positive, anti-nuclear antibody is positive, so that's also not a specific diagnostic test for your rheumatoid arthritis, because SLE will also have ANA. Okay, so if a patient just comes with a mild joint pain and morning stiffness, then you will just give them acetaminophen. You will tell them to take NSAIDs, some topical agents. So these going to be their remedies. And then you can also advise the patient to do RICE. What is RICE? Rest, okay, right? And then I for icing, okay, and E for elevating and compressions. Fine, so they need to rest their joint. Next question. Patient of osteoarthritis usually have relapse and remission of pain, especially knee joint, and then on long-term medicine. So they are put on long-term maintenance therapy, usually cause acid peptic disease. How to prevent this, and which medicine cause least gastric problems? So the prevention is to give the medication that is not causing the peptic ulcer disease. We have silicosib, okay, that's COX-2 inhibitor. I would like you guys to see this diagram over here to better understanding of what is NSAIDs, why NSAIDs are causing acid peptic disease, and why COX-2 inhibitors, silicosib, is not causing it. So please do follow. We have arachidonic acid that are going to make our prostaglandins. So we have different kinds of prostaglandins, and they are going to work on different things. So we have protection of gastric mucosa. They help in homeostasis. Okay, they can cause inflammation and pain and proliferation, angiogenesis, different things also. So the enzymes that convert arachidonic acid to prostaglandins are COX-1 and COX-2, cyclooxygenase 1 and cyclooxygenase 2. So our NSAIDs are the one, they inhibit COX-1 and COX-2 both. Means that when they inhibit COX-1, I don't have any protection against my gastric mucosa. So I'm going to have what? Peptic ulcer disease. Okay? But what I'm doing, this NSAIDs, I take ibuprofen all the time. I said that, yeah, my pain is gone. My pain is gone, and the woman keep taking it. The patient, I have across a patient that she used to take a lot of ibuprofen, 800 milligram every time, every 3 hours, like 4 hours she's taking, because what she says that my pain is going away. But what is happening, that she came with the vomiting, hematemesis. So hematemesis, what is going in? Gastritis, because there was no protection of gastric mucosa left, right? So, but if we give them COX-2 inhibitors like silicosib, look at what they are going to do. Only COX-2. So these COX-2 are the one, they will just help them with reducing the inflammation and pain, but they are not touching your protection of the gastric mucosa. They are not inhibiting that part of prostaglandins. Okay, so my gastric lining is still protected. So for long-term treatment, we can give them silicosib. Next question. Please explain what is anti-CCP. So anti-citrullinated proteins antibodies are autoantibodies against individuals' own proteins. Okay, means autoantibodies means they are destroying your own proteins. They are the good one, they are destroying your that. So they are directed against the peptides and proteins that are citrullinated. So they go and direct those and destroy those. These are the proteins they have citrullinated. So they are present in majority of the rheumatoid arthritis, these autoantibodies. So what we do when clinically we do a lab test, so we see that we have anti-citrullinated peptide antibodies. So what is happening? This is anti-cyclic citrullinated peptides are type of autoantibody that attack your own healthy proteins, okay, tissue. High anti-CCP levels can help diagnose rheumatoid arthritis. Okay, so what they are predicting that they have more progressive activity of the diseases going on if you see anti-CCP in rheumatoid arthritis patient, because it can be still negative and you can still have rheumatoid arthritis. Okay, so but if you see that positive anti-CCP, means that disease is aggravating. So this is important to remember. Are intraarticular steroids absorbed systemically? Yes, they are. Are oral and injectable vitamin D equally effective? Okay, oral and injectable forms of vitamin D are effective, but injectable forms have shown more efficacy than your oral one. So there are no undesirable effects, side effects, and both forms of treatment are well tolerated. So you can give them injectable, you can give them oral, but injectable have shown more significant effects. If a vitamin D is less than 15, what is the dose and duration of treatment? So what are you going to do? You are going to give the patient 20,000 international unit per week for 2 months. Guidelines say that a patient needs to have 2,000 to 3,000 per day. Next question. 30-year-old male having early osteoarthritic symptoms and vitamin D levels of 23 has bought vitamin D calciferol tablets of 200,000. What is the regimen to be prescribed for such high dose? So what are you going to do? Once a month for minimum 3 months. Okay, just once a month the patient is prescribed to take that. How to treat vitamin D toxicity? So vitamin D toxicity, when is going to happen? When patient is exposed to a lot of sun, okay, they are working all the time outside, or they are taking too much of vitamin D, okay, and they are taking too much of calcium. So number one thing, what are you going to do? You're telling them limit your exposure to the sun. The second thing you're going to do, you're going to stop vitamin D supplementation, and you will stop calcium supplements also, and you will give a drug that calls a ketoconazole that blocks the enzyme 1-alpha hydroxylase that is converting your inactive vitamin to active vitamin. Okay, because we have toxicity, right? So we don't want more any vitamin D, active vitamin D. So this enzyme 1-alpha hydroxylase that's present in the kidney, in the proximal tubules, so their function is from the liver, the inactive vitamin D is converting into active vitamin D in the kidney. So now if a toxicity is there, so we need to control that part also, right? Yeah, you stop the vitamin D, yeah, don't take calcium, limit the sun exposure, that will help you, yes. But still, then we have ketoconazole, corticosteroids, and hydroxychloroquine, we can give them that. And if they have severe hypercalcemia, too much of calcium is there, why they will have severe hypercalcemia? Because the function of vitamin D is to reabsorption of calcium, right? Resorption of calcium from the bone also. So that's their vitamin D function. So if too much of vitamin D, they are going to reabsorb too much of calcium. So severe hypercalcemia will be treated with diuretics, hydration, and then we can give them steroids. So these are the things that we can give them. But if the patient cannot tolerate excessive hydration, because we have to give aggressive hydration to them so they can excrete the calcium. So if a patient, he cannot tolerate excessive hydration, so what are we going to do? Peritoneal or hemodialysis for these patients. Okay, so what are we going to do? We will place the patients with vitamin D toxicity on a low calcium diet. We can give them calcium sodium editate to increase their fecal excretion of the calcium. We can give them ketoconazole or corticosteroids to inhibit the enzyme 1-alpha hydroxylase that is converting your inactive vitamin D to active vitamin D. Make sense? Okay. Doctors also prescribe vitamin D injections which are taken as syrup. What is the difference in efficacy, bioavailability, half-life of an IM injection versus an oral syrup? So one thing, oral is what? It has to go through a lot of phases. Okay, so they have biotransformation is happening in the liver. But when you give them IV injections or IM, they skip some of those phases and they go directly into the blood to start working. So your injections will have better bioavailability efficacy than your oral syrup. Next question. For how long patients have joint pain after chikungunya virus? How to confirm a diagnosis other than history? So the virus, the symptoms of this virus, the patient can come with severe joint pain also that develops like right after, but it remains for 3 to 5 days. But sometimes it takes about 1 to 2 weeks to resolve, completely need to get out. So it takes about 1 to 2 weeks. So when the patient is infected with it, they will have severe joint pain, muscle pain, okay, joint swelling will be there, fever is there, rash is there, headaches are there. But your joint pain is the one that remains for 3 to 5 days, but completely will resolve after 1 to 2 weeks. Then they have how to confirm diagnosis other than history, because these are the symptoms the patient are telling you. But what other things can you do? So we can do serological testing, we can do viral culture, and we can do molecular diagnostic tests like reverse transcriptase PCR testing. Okay. Next question is, how is the spine misalignment treated? So misalignment is treated first with walk, stretch, and planks, and then surgery is towards the end. So corrective surgery is being used, and if non-surgical methods have failed to improve the symptoms, okay, they are showing you signs of neurological symptoms, and symptoms have become more rapidly progressive, and their life is affected because of this. So what we will do, misalignment is often corrected, okay, with spinal fusion therapy. So spinal fusion therapy, what is it? The spine is fused in a correct position with the screws and rod. So it was tilted, misaligned, look at that, and then they correct that thing. So I would like to thank the following trainees for their questions: Dr. Madhya, Homa, Sadaf, Mehnaz, Nashita Farhim, Rahat Saeed, Shireen Rahmat, Alia Malik, Samina, and Mariam Zubair. E-Doctor would like to thank the following trainees for screening of questions: Dr. Saima Bhatt, Dr. Fiza Yasir, and Dr. Anam Zaidi. Good luck to all of you. It's a great project. I hope you will get benefit from it.